Okay, hello and welcome everyone to another MMS info session. As you all probably know by now, these sessions are offered under the CMS Measures Management System contract, which is held by Battelle. I'm Brenna Rabel and I oversee education and outreach on this project. So today's session is all about specifying quality measures with a particular focus on eCQMs. And I'm joined by my colleague, Dr. Meredith Eastman, who, in addition to serving as the CMS pre-rulemaking task lead on the MMS contract, also has years of experience developing and testing clinical quality measures and providing technical experience to new measure developers. And as you know by now, these info sessions are, part of an ongoing effort that we oversee to engage measure developers and other stakeholders in quality measurement topics. And that's an effort that also includes a series of newsletters, along with special announcement emails, public webinars, and routine updates to the Measures Management System website. These info sessions occur on a monthly basis, and we do that so that we can continue to provide up-to-date information on a wide range of topics that are related to quality measure development. Now, before we jump into today's presentation, I do want to cover a few housekeeping items. The first is that today's session is being recorded. And second, all the participants today are going to be muted during the call. We are going to have an opportunity for Q&A at the end of the call, during which we encourage you to enter your questions into the Q&A feature. Me or my colleague Kate Buchanan will read those aloud to our presenter during to facilitate that discussion. And you can see on the screen here the instructions for how to do that. And finally, the presentation slides from today's session are going to be posted to the MMS website for your reference. They'll be updated in a week or so with notes from today's session, and then the recording of today's presentation will be posted to the CMS YouTube page on a later date. And with that, we can jump to the next slide, and I'm going to turn it over to Dr. Meredith Eastman for the presentation.
Great. Thank you so much, Brenna, and thank you all for joining us today. As Brenna mentioned, we'll be focusing on a key step in the clinical quality measure development lifecycle, which is the measure specification stage. And just as an overview of what I'll be covering today, I'll start by describing what measure specifications are and locate the measure specification process within the measure lifecycle. We'll talk about key components of measure specifications and what kinds of information can influence those specifications. We'll spend some time going through each step of the measure specification process, and then I'll touch on some specific considerations for electronic clinical quality measures. I'll point you to some resources that are available to support the development of measure specifications, and then we'll have some time for questions at the end. And feel free to put those questions in the Q&A at any point during the presentation, and we'll address them at the end. So that's a lot to cover. So let's get started by defining what we're talking about here. So what are measure specifications? Measure specifications are a comprehensive set of technical instructions for how clinical quality measures are collected and implemented consistently, reliably, and effectively. And those last three adverbs there are critical. We want those specifications, those instructions to leave very little to the imagination so that two people with the same set of specifications end up with the same result. Specifications provide details for what information about the measure will be collected, what information will be excluded, how that information will be collected, and how it will be reported. So those are sort of the questions that are addressed by a set of measure specifications. Here is a diagram of the measure lifecycle taken from the Measures Management System blueprint. And you can see that measure specification generally occurs between conceptualization and formal testing. However, as with nearly all aspects of the measure lifecycle, measure specification occurs iteratively. Now, prior to initial specification development, developers consider what data elements are available that are necessary to operationalize the measure concept. It's a good idea at this point to conduct some preliminary feasibility estimates and assessments on those data elements that you need to ensure that the data for your measure can actually be feasibly specified and obtained. Once that initial feasibility assessment is fulfilled, you can move forward with drafting the initial specifications. The measure's technical expert panel should weigh in on the draft specifications, and in fact, specifications may go back to the TEP multiple times for input during the process. Public comment can also be sought on draft specifications, and those comments can be reviewed and taken into account by the developer. Testing efforts, both alpha and beta, may also result in refinements to specifications, and those refinements must be tested in turn. So you see that bidirectional arrow between measure specification and measure testing. As the specifications become refined, they must be further tested. So we're going to talk about each step in the measure specification process in greater detail. But to sort of help us define more what we're talking about here, I'm going to describe some components of measure specifications. So measure specifications generally include the components on this slide, but it's important to know that not all components on this slide will necessarily be included in each and every measure. In general, however, we're talking about the measure name, the measure title, the measure description, the initial population, numerator statement and definitions, numerator exclusions, the denominator statement and definitions, and denominator exclusions, denominator exceptions, the target population, the time intervals for the measure, any stratification scheme, any risk adjustment methodology, the calculation algorithm for the measure, any sampling methodology, data sources for the measure, any key terms, data elements, codes, and code systems, and also the level of analysis for the measure and the attribution model. So we're going to talk about some of these components in a little more detail, but in general, that's sort of the universe of components for measure specifications. But how do you determine what all of these components should be? There are multiple sources of influence for measure specification development. The primary sources that should be consulted are on this slide, and they include things like existing measures that may have a similar focus. So you want to make sure that your measure is not duplicating existing work, that any differences from existing measures are sufficiently justified. You want to review the literature on the measure topic. You want to get your input from the technical expert panel and subject matter experts. You can solicit public comment, as I mentioned before, and results of alpha and beta testing are also going to influence the measure specifications. And finally, clinical practice guidelines may be consulted. So all of these sources are sort of synthesized to determine the specifications for clinical quality measures. So we're going to talk a little bit more about the process for developing measure specifications. The steps of the process are on this slide, and we start with defining the data source for the measure. Then you develop specifications and definitions. I will say this sounds a little circular to say that you develop specifications in order to develop specifications, but what we really mean here is you're developing definitions for measure components and data elements. The next step is to specify the codes and code systems for your data elements, and then to construct the data protocol. And that's really a description of how the data are aggregated or linked to calculate the measure. And the last step is to document the measure. And although that is listed last in the list of steps here, it's something that occurs throughout the process, and it's iterative throughout the specification development process. So we're going to talk in greater detail about each one of these steps in sequence, starting with defining the data source. So potential data sources for a measure are listed on the slide, and they include administrative data, claims data, patient medical records, and that could refer to electronic health records or paper records, electronic clinical data such as device data, registries and QCDRs, standardized patient assessments, and patient-reported data and surveys. Now, each one of these data sources has its own set of strengths and limitations, and a sort of deep dive into those strengths and limitations is beyond the scope of our presentation today, but it's important for developers to consider those strengths and limitations and to consider the feasibility of the method of data collection carefully when determining a measure's data source. This is critical because the data source that is used to calculate a measure essentially determines the reliability, validity, feasibility, and usability of the measure. So it's a critical decision, and it has implications that will be carried forward throughout the process, and we'll touch on what some of those are. If multiple data sources can potentially be used for a measure, for example, if you're using both EHR and chart abstracted data, then specifications must be developed for each data source, and the developer has to document that the results from those different data sources are comparable. After you've determined the data source you'll be working with, you can begin to develop your specifications and definitions. When we're talking about the process of developing specifications, we're really talking about adding increasing amounts of detail to the measure concept, especially with regard to the measure's initial population, the denominator, the numerator, which applies to proportion and ratio measures, any exclusions and exceptions, and any stratification schemes. So we're going to talk about each one of these components a little more. We'll start with the initial population. So the initial population refers to all individuals that are evaluated by the specific performance measure who share a set of common characteristics. During the specification process, you're defining what those shared characteristics are. And the initial population comprises a cohort from which the denominator population will be selected. Details that can be specified for the initial population include things like age groups, diagnoses, specific diagnostic or procedure codes, or enrollment periods. From the initial population, we move to the denominator, which is the population evaluated by the measure. This could be the same as the initial population, or it could be a subset that further constrains the measure. Parameters that define the denominator often include things like age ranges, settings, diagnoses, procedures, time intervals, or other qualifying events, for example, a look-back period. As we go through the measure components in this section, and as you become exposed to more measures, different types of measures, you'll see that narrative specifications tend to follow a certain formula or recommended format. For a denominator statement, you can start by describing the patient, their age range, then a condition of interest in a specific setting during a specific time frame. So on this slide, we've included a couple of examples of denominator statements from the Centers for Medicare and Medicaid Services Measure Inventory Tool, or CMIT. The CMIT ID in parentheses at the end there is not part of the specification. It's just a tag or reference number for the measure. But our first example is a fairly simple and straightforward example. All patients aged 18 and older with a diagnosis of chronic obstructive pulmonary disease. And that sort of follows the formula that's at the top of the slide there. A description of the patients, how old they are, and the diagnosis that they share. The second example adds a little more complexity. All patients at least 18 years old as of the first day of the reporting month who were determined to be maintenance hemodialysis patients in center and home hemodialysis for the complete reporting month at the same facility. So there's a lot more parameters in that denominator than in the first one, but again, that formula is kind of the same. The same structure is being followed in both cases. So it's possible that The denominator inclusion statement may be all that's required for your measure. But what if you want to remove patients from the measure if certain conditions apply? There are two ways in which this typically occurs. Those are denominator exclusions and denominator exceptions. This gets a little confusing, so I encourage you to just stick with me through the next few slides, and we'll provide some examples that will help clarify the differences and talk about appropriate use of each type, exclusions and exceptions. So denominator exclusions on the left of the slide are criteria that result in removal of individuals from the denominator before calculating the numerator. For these folks, the numerator is simply not applicable. They've been excluded prior to calculating the numerator. On the right hand, we have the denominator exception. This allows providers to get credit, so to speak, when the numerator action is performed, but their score on the measure is not negatively impacted if the numerator is not performed for an appropriate reason. So the exception allows for clinical judgment. The numerator action was considered for all patients, but some were accepted for legitimate reasons. So let's look at some examples to help clarify what these two components are. On the left, we have an example of a denominator exclusion. So we have women who have had bilateral mastectomy are excluded from the denominator of a measure of screening mammography. The numerator action, in this case, a screening mammography, simply doesn't apply to these individuals as they've had a bilateral mastectomy. So we remove them from the denominator before even calculating the measure. An example of a denominator exception is here on the right. Asthma in the use of beta blockers for heart failure. So in this case, the clinician weighs the risks and benefits of administering beta blockers. If the provider does not administer beta blockers, which is the numerator action for this measure, the medical record would be reviewed for the presence of a diagnosis of asthma, and the individual will be removed from the denominator. In this case, the score is not negatively impacted because the provider used clinical judgment to determine the appropriateness of the numerator action. So to help further clarify the differences here, what are the circumstances where you would consider specifying a denominator exclusion versus a denominator exception? The goal of a denominator exclusion is really to define the measure's population without overreaching or underreaching. So you want to consider specifying an exclusion if the potential exclusion condition occurs with a frequency that would otherwise distort results. So this isn't a situation that applies to one or two individuals. It's something that has a prevalence that has the potential to distort those results. You want to consider an exclusion if there's evidence that measure validity is improved when the exclusion is applied. And you want to consider an exclusion if there's evidence that face validity is improved when it's applied. So you may have noticed that each one of these considerations for denominator exclusions can be tested during the measure testing stage of the measure lifecycle. So prior to testing, developers may cast a broad net, defining a set of exclusions broadly, listing multiple exclusions that may or may not improve measure validity, and then testing these exclusions and narrowing down that list depending on what the results show about the appropriateness of each exclusion. Under what circumstances would you consider specifying a denominator exception? Denominator exceptions will only be relevant in a proportion measure, and they should be considered if there is a precisely defined and evidence-based medical reason for the exception. If patient preferences may determine the numerator action, so if there's choice involved there, or, and this should be rare, if there's a possibility of system inadequacies. So again, we want to limit use of exceptions for these possibilities, but it may make sense to note exceptions if there's a potential for a vaccine shortage, for example. So having gone through the denominator exclusions, and denominator exceptions, we can now talk about the numerator. The numerator is the process, the condition, the event, or the outcome that satisfies the measure's focus of intent. Parameters that may define the numerator could include things like an event that satisfies the numerator inclusion criteria, could be the performance period or time interval for the numerator event, and this must be specified if it's different from the time period that's used in the denominator. And just as with the denominator statement, there is a formula for writing a good numerator statement. In general, the numerator will state the numerator action that patients experience and the time frame if that time frame is different from the denominator. So again, we have two examples from CMIT here. The first one is our more simple example. Patients with documented spirometry results in the medical record. That's our first example of a numerator statement. Following the formula, we have patients who had their results documented in the record. Our more complex example, still following that formula, however, is the number of adult patient months in the denominator who were on maintenance hemodialysis using a catheter continuously for 3 months or longer as of the last hemodialysis session of the reporting month. So that's much more detailed, but it follows the formula, and I want to just call out here how specific the time period and the time frames have been specified in this example. Again, it's important, particularly if the time frames are different between your denominator and your numerator, to make those time frames explicit. So to add to our complexity, I'm going to spend just a minute talking about numerator exclusions, which are relevant only for ratio measures. For these measures, a numerator exclusion defines elements that should not be included in numerator data. So an example of this would be if the measure is about central line bloodstream infections. If the number of central line bloodstream infections per 1,000 catheter days were to exclude infections with a specific bacterium, then that bacterium would be listed as a numerator exclusion. And again, this is only seen for ratio measures. So we've gone through all our various components, and the next slide is sort of a graphical depiction of the anatomy of a hypothetical measure. It's hypothetical because it includes all the components we've just discussed, so you can sort of visualize how the components relate to one another. As I mentioned, not all measures will have all of these components, so you can see that the broadest category is the initial population in that light blue color, which is further constrained as the denominator, with holes for denominator exclusions and exceptions. In red is the numerator, with a hole for that rare numerator exclusion. So as part of the specification process, you also want to consider stratifying the measure based on risk for the outcome of interest. Stratification can help detect and quantify disparities related to the measure focus between different racial or ethnic groups, for example. In order to do the statistical stratification, you need to make sure that you identify and define what those stratification variables are in the measure specifications. We have an example from CMIT here describing stratification. The measure is to be stratified by a population type, i.e. race, ethnicity, age, social risk factors, income, region, gender, primary language, and disability. It's important to note, though, that stratification is not always appropriate. There may be statistical or other reasons not to stratify. For example, cell sizes could become so small that patient identification is feasible, and that's one reason you would choose not to stratify a measure. However, consideration of stratification should occur during the specification process so that you're able to collect information about the variables of interest. So we've just defined all of our measure components. Now it's time to specify codes and code systems to add additional precision to the specifications. Most measures rely, at least in part, on the use of standardized codes or code systems for classifying healthcare. These code systems include things like the ICD, CPT, SNOMED, and RxNorm, among others. Measure specifications should include all the required codes needed for the measure and the code system as well as the version from which they come. Measure developers must ensure that the code system versions they reference align with the timeframe of the testing data, which could potentially span multiple versions of a code system. For example, a measure may reference the current version of a code system for a current diagnosis, but they may reference a prior version of the code system to capture denominator exclusion diagnosis that occurs during a look-back period. So it's important that those versions are recorded in the specification. Additionally, specifications may require that codes accompany other codes. So we're looking at codes and combinations, that those codes occur in a specific location within the medical record, or that they occur in claims from specific types of providers. And as a final consideration, some code sets, the CPT is one example, may require copyright statements to accompany their use. The next step in the measure specification process is to construct the data protocol. Again, here we're talking about defining how to aggregate and link the data so that measure calculation is reliable and valid. So measure calculation may very well require merging of data, which comes with some potential challenges, a few of which are listed here. So the first one is identifying duplicates. If you are merging multiple data sets and you're having to link patient IDs across multiple sources of data or data sets, you may have to develop a way to identify duplicates or resolve duplicates. Different data sources and data sets may use different units of measurement that require conversion. They may use different code sets and may have different quality controls in place. So all of these are important pieces of the puzzle to consider when merging data. It may very well be necessary, probably likely, to perform data cleaning to ensure that these problems are addressed prior to measure calculation. So hearkening back to our previous step, key terms in the numerator, in the denominator, in exclusions, and in exceptions must be precisely defined using the codes and code systems that have been selected. So if the measure references up-to-date vaccination status, the developer needs to specify which specific vaccinations are being referred to, as well as the definition of what qualifies as up-to-date. So again, we're getting more and more specific here and using codes and code systems to define the data elements we're interested in. So aspects of the data protocol that might be required are dictated by the measure's data source. So recall that we determined the measure data source back in step 1, but here's an instance where the implications of that selection are carried forward. So for example, if the data are coming from a patient medical record, the developer must develop instructions for data abstraction. So this includes what terms from the record are allowable, where in the record those terms may be found, and what the appropriate values for the measure are. These instructions must be clear enough so that each person collecting the data for the measure will interpret the specifications in the same way. So for example, if we wanted to talk about the data element hypertension, are we looking for the word hypertension in the medical record, or is an abbreviation HTN acceptable? How about high blood pressure or an upwards arrow and the abbreviation BP? Are those acceptable terms for data abstraction? Allowable places within the record might be the problem list, the history and physical notes, and any progress notes. So you need to specify where we're looking for these data elements as well. If, to take another example, the measure is using claims data, the developer must specify what type of claim is being used, what data fields are being referenced, and what code types and specific codes are to be captured. So here we have an example of a measure from claims data. with very specific instructions for which claims are being looked at, what the ICD codes are, and what ICD codes are excluded. The specification should also include the unit of analysis or the attribution for the measure. That's defining the primary entity to which the measure should be applied. This attribution should be justified explicitly and should be specified with the broadest applicability supported by the evidence. It's important to note here that reliability and validity must be tested appropriately for the level of analysis. You can't assume that reliability and validity hold across different levels of analysis. So measures must be retested for each setting, each population, or each level of analysis to which they are being applied. You can't take for granted, for example, that a measure that has been specified for the facility level will perform reliably and validly at the clinician level. If the measure requires sampling, the specifications should describe the sample size or provide guidance for how to determine that sample size and describe any methodology for conducting the sampling. Risk adjustment, if applicable, must also be discussed in the data protocol. Risk adjustment should be considered if there are risk factors that exist outside the healthcare encounter that may affect the outcome, regardless of the quality of care received. Risk adjustment can facilitate fair and accurate comparisons of outcomes across healthcare organizations, providers, or other groups, but it's not appropriate in all cases. For example, process measures typically are not risk adjusted. If it is being used, however, developers should explicitly test and describe the risk adjustment methodology so that it's transparent and clear for the measure calculation. Measure specifications, as we've discussed, must also precisely define time intervals for inclusion, for exclusion, and for timing of any index events. Time intervals may also define how often to report the numerator or how to include patients in the denominator. So when defining your time intervals, it's important to avoid ambiguity, use and specify exact units, and to explicitly state any look-back periods. The data protocol should also include the scoring type of the measure. Is it a rate? Is it a count? A ratio? And how the score should be interpreted. And on this slide, we have a few example interpretation statements that may be useful. So in the first example, we simply state that higher score indicates better quality, improvement noted as increase in rate. Or a lower score indicates better quality, improvement is noted as a decrease in median value. Or a score within a defined interval indicates better quality. So it's important to provide guidance on how to interpret the measure scores. Lastly, the data protocol should include the calculation algorithm, which is the ordered sequence of data element retrieval and aggregation, which describes the path of the raw data to the measure score. This can be represented graphically, for example, in a flow chart diagram, or narratively, or a combination of the two. This algorithm is critical because it becomes the basis for any subsequent computer programming to calculate measure results. So, now that we have gotten through the data protocol, it's time to talk about documenting our measure. And again, although this is the last step in our list, it actually should occur iteratively throughout the specification process. It's important to have documentation of the technical specifications and any additional documents that may be required to evaluate and implement the measure as it's intended. A few documents that can assist with documenting specifications can be found in the Measures Management System Blueprint, and they include the Measure Information Form and the Measure Justification Form. For eCQMs, documentation occurs in the measure authoring tool, or the MAT, where measures are expressed using clinical quality language. So CQL is an HL7 standard that is a clinically focused and author-friendly language that enables precise measure specifications. It provides the ability to express measure logic in a way that's human readable, yet structured enough for processing a query electronically. The MAT is capable of exporting eCQM specifications in both human and machine readable formats. So how does the specification process differ for eCQM? Spoiler alert, it basically doesn't. The specification process is largely the same until we get to the documentation step. Precise written specifications in plain English will actually facilitate translation into CQL using the MAT. Differences, however, are that specifying a measure in the MAT requires that value sets for relevant codes be linked to the Value Set Authority Center, the VSAC, and that any measure logic that's written through your MAT entry can be tested using the linked Bonnie tool. And so you can go forward with coding in the MAT sort of alongside your development of narrative specification, or you can wait until everything is finalized and then start, coding in CQL. It occurs iteratively and depends sort of upon the complexity of the measure. The documentation process for eCQM specification is depicted on the left side of this diagram. So it says measure specification phase under that cloud. So that's what we're going to focus on. And here the measure developer is using the linked tools of the MAT, the VSAC, and Bonnie to express the measure in CQL. If you haven't seen the MAT before, here is a screenshot of what the interface looks like. You can see there are places to record value sets, codes, parameters, definitions, and functions. If we were to click on the CQL library editor at the bottom of that menu on the left there, we might see something that looks like this. This is what the actual CQL syntax looks like. There's color coding that you can see to denote different types of syntax. So, there's green for comments that are, not part of the code, but are the programmer's comments about the code itself. And you can also see that little green box at the top of the screen is showing that there's a built-in validation check to ensure that the code is free of errors. So as you're working through, you will get an error message if there's something in the code that's not correct. And here we're happy to see that green box letting us know that everything is going well. So we've covered a lot of ground today, but I wanted to leave you with some resources where you can learn more about measure specification. The Measures Management System Blueprint is an excellent resource where you can find templates for the measure information form and the measure justification form that we've discussed previously. For additional guidance on measure specification, I would point you specifically to Chapter 5, entitled Specification, and to supplemental materials on codes, code systems, and value sets, and on eCQM specification, testing, standards, tools, and community. So those are the two supplemental materials that are most relevant for the specification process. If you're working on an eCQM, I highly recommend checking out the eCQI Resource Center. It's a great place to seek out more information about eCQM specification in particular. And with that, I think we can look at the Q&A for questions.